lecture series of the first webinar by the SRM Cons Endo alumni students. It is indeed a great pleasure to introduce again. We had on 27th of, that is day before yesterday, we have had the beautiful ladies doing the show. Today we have the handsome men who will be giving lectures on 3 different topics. We have Dr. Arun from the 2013 to 16 batch. Then we have Dr. Santosh from the 2015 to 18 batch, and Dr. Manish from the 2016 to 19 batch. So without further delay, I now call upon Dr. Ravi Kumar to introduce Dr. Arun.
Good morning, madam. Good morning to all. Dr. Arun has completed his BDS in Vanaga Mission Sankaracharya Dental College in 2010 and PG in Conservative and District Endodontics from SRM Dental College in 2016.
Ravi,
yes, madam.
Can you please hold the mic a little closer?
Yeah, okay.
Yeah, thank you.
Now he is working as an associate professor in VMSDC Salem. Now he is various publications in national and international journals, and also he is a reviewer in international journals. He delivered guest lectures at state and national forums, and also he is a CDA convener in IDA Salem branch from 2017. He has undergone extensive training in the use of dental operating microscope, aesthetic designing, and in regenerative endodontics right now in the clinic. Welcome once again, Dr. Arun. Over to you.
Thank you, sir. Thank you so much. And it's a privilege and honorable moment that I'm getting introduced from my teacher and well-wisher. Thank you, sir. Thank you so much. Sorry. Whenever I'm starting my presentation in the state and the national forums, before starting, I will show, I will display this picture, and I will inspire, and I will show this inspired quote that the task of the excellent teacher is to stimulate apparently ordinary people to unusual effort. These people made me today where I am standing now. So whenever I am getting to the next level in my career, I will always thank my teachers and this team, especially. Okay, moving into the topic today is I'm most inspired and I like this topic very much. And I started my clinical practice in this topic nowadays, that is regenerative endodontics. So before moving into the subject, I would like to show one of my case. I have done around 40 to 43 cases in my clinics, and I started exclusive regenerative practice, and I have attached my clinic with a pathology lab, and I have started my regenerative cases 3.5 years back, and this is my 11th case, and this case has came with a good, excellent result. I am displaying this photo particularly, and I'm having all the patients, around 37, 38 patients follow up. Really, it's going good, and also most of the around 18, 21, 22 cases, I'm having good success in the results. So this patient comes to an dental OP, a fracture and trauma of anterior 1-1, and of course I have the patient age was around 16 years, and the history of trauma was 6 years, 7 years back. So immediately I have taken an X-ray radiograph, and I can able to see the open apex. And then I decided to do the regenerative procedure. So once after complete investigation, that is history from the patient, then examination, then vitality, checking the vitality, and final radiographic investigation. After the diagnosis, then I come to a treatment plan. Always, in case of open apex tooth and trauma, we will go for an apexification. Immediately, we will come to a mind that either 2 treatment options, either apexification with RCT and post-endodontic restoration, then regenerative or revascularization procedure. So I have explained these 2 procedures to the patient, and I have mentioned that advantages and disadvantages, treatment procedures. Whenever I'm starting the patient, I will explain both the treatment procedure and the advantages as well as disadvantages, and I am very conscious about convincing the patient to and creating awareness to the patient to a regenerative procedure. And finally, patient once agreed for regenerative, then I will proceed with an treatment, and starting with an consent form, getting signed from the consent form, and start up with the LA administration at the first appointment, and under rubber dam isolation, coronal access prepared, then irrigating with sodium hypochlorite, canal dried, and placing an intracanal medicament followed by cavity. At the second appointment, after 3 to 4 weeks, recall the patient and checking for any signs and symptoms, then remove the temporary restoration and remove the intracanal medicament, and dry the canal, collecting the blood from the vein, and prepare the PRF and separating the PRF from the test tube and placed inside the root canal, and coronal, and over that resorbable matrix has been placed. Over that, below the CEJ 3 mm, placed an MTA, and over to that resin modified glass ionomer has been kept. Okay. So after 3 months, I recalled the patient and I have taken the X-ray. Unfortunately, I have taken an RVG. My software got corrupted, so I am not able to save that 3 months follow-up X-ray. But after 6 months, I can able to notice that radio opaque at the coronal middle third of the root canal, as well as I can able to see in the increase in the size of the root length as well as thickness in the root length. And of course, after 12 months, I have undergone a vitality check also, and I can able to see the positive results. And from that, I am so much inspired, and I am started doing the regenerative procedure in more number of cases, and patient was very happy, and finally I have done with an composite restoration treatment. So this was the one of my case I have displayed, and planning to publish all the success case in articles in future. So what is this regenerative? What is the exact mechanism behind this regenerative? What is the importance in this? So we have to take this regenerative into the next level. So we, the endodontist, have to start practicing the regenerative treatment and creating the awareness to the patient for better survivability of the tooth. Okay. So coming to the theory parts. We all know that once the teeth gets damaged due to any caries or trauma, its vitality in case of eruption period, its vitality gets damaged. After that, the root length, increase in the root length and the closure of apical foramen, it gets disturbed, and then the maintaining the pulp vitality is completely disturbed, and the development of root as well as apical closure is damaged. So once in this kind of teeth, so automatically we will decide the treatment choice. First choice is apexification, that is removal of that necrosed pulp and application of calcium hydroxide or MTA at the apical to avoid the obturating material getting penetrated into the periapical region. So this is the one of the treatment choice, apexification for the open apex. And this induces only the apical closure. It can't maintain the pulpal vitality as well as the increase in the root dentin thickness. So the main drawbacks for this apexification procedure, either both calcium hydroxide as well as in MTA. That is, this calcium hydroxide is replaced, it should be replaced every 3 months, and long-term follow-up needed up to 1.5 years to 2 years. And the main disadvantage, the main drawback is there is the possibility of root fracture, because the flexural strength of the dentin is linked between the hydroxyapatite crystals and the collagen. Okay, so the alkalinity of this calcium hydroxide, it will affect that link, and it will weaken the hydroxyapatite crystal, and it will leads to weaken the dentin, and finally the root dentin gets more prone to fracture. So still more leniently, still more you want, means if you see a sponge, okay, if you cut the sponge, at the middle of the sponge you can able to see the round cross sections, that is spaces between all the cross sections. That is what the said calcium hydroxide will be exhibit. So there will be a porous in nature in the said calcium hydroxide. So coming to the MTA, it is a single visit, that is good, but there is a discoloration, chances of getting discoloration. Then during, in case of reinfected, or if you want to do any periapical surgery, it is difficult to retrieve. So in 1971, Dr. Nayagat Osbe is the first one to introduce this regenerative endodontic treatment procedure in the dental field. And in 2001, Dr. Ivaya is the first one to do the treatment procedure, revascularization treatment procedure in the patient. According to Banks and Trope, they suggested that this treatment procedure is to replace the damaged pulpal tissue with the viable tissue. It's going to remove the necrosed tissue, and it is going to regain the vitality to the tooth surface. So AE has given a definition that this is an biologically based procedure designed to physiologically replace the damaged tooth structures, including dentin and root structures, as well as the cells of the pulp dentin complex. Okay, what is the main advantage of this regenerative protocol? Okay, in this regenerative, we can able to see the complete root development, and also in short term, it will causes the root dentin thickness, and very importantly, we can able to regain the vitality to the tooth. Okay, coming to the theoretical part, we'll go deep into the theoretical part. This regenerative endodontics is comprised of guided tissue regeneration. This is comprised of tissue engineering. This tissue engineering is composed of revascularization and revitalization. This revascularization is nothing but re-establishment of vascularity in the pulp space and post-injury to the original vascularity of the pulp. Whereas revitalization is non-specific vital tissue rather than the blood vessels. So this is the difference between the revascularization and revitalization. This revascularization, it will establish the pulp blood supply to the pulp. Okay, as well as the revitalization, it is a non-specific tissue will be present rather than the blood vessel. So this all together is forms, it induces the physiological root formation. This results in the tissue regeneration. Now, the main key ingredients of this regenerative treatment procedure is, it is based on stem cells, growth factors, and scaffolds. So without any one is missing, without any one of the ingredient, it can't take place completely. So these stem cells, scaffolds, and the growth factor together, it involves in the incorporation of ex vivo expanded stem cells and growth factors incorporated within a three-dimensional natural or synthetic polymer that provide an environment for cell proliferation and the differentiation. And very important, the fourth key ingredient is conducive environment. So even these stem cells, scaffolds, growth factor, all these three ingredients plays a good role, but the environment is not properly sterile. The environment is not in good condition. These will not work properly. So the main important ingredient is environment, conducive environment. Okay. We all know that stem cells, it has two properties, self-renewal and the plasticity. This self-renewal is the property of cells to divide, producing more of themselves, whereas plasticity is differentiated into different mature cell types and explained by the term. Okay. So normally, always the embryonic stem cells are more valuable in tissue engineering due to presence because of their pluripotency and greater plasticity properties. So most of the stem cells which are found in the orofacial region are mesenchymal stem cells. You can able to see the dental pulp stem cells from apical papilla, stem cells from the human exfoliated deciduous tooth, periodontal ligament stem cells. Many stem cells are present. But in regenerative procedure, the two main important stem cell is dental pulp stem cells and the stem cells from apical papilla. These dental pulp stem cells are isolated from the dental pulp, and it has an capable of regenerating the odontoblasts with the mineralized tubules and fibrous tissues with the blood vessels. Whereas stem cells from apical papilla, it has an unique postnatal stem cells, and it is found in the root canal space, and it can be initiated into the root canal space from the apical papilla by lacerating the apical region by using the file. And it has a greater capacity for dentin and tissue regeneration than the dental pulp stem cells. Yeah, of course, the studies also proven that they have stated that these stem cells from the apical papilla has differentiated into odontoblast-like cells, and this helps in formation of the root dentin, whereas the dental pulp stem cells are differentiated into odontoblast-like cells, and this results in the formation of dentin pulp-like complex. So these two stem cells plays a major role in the regenerative procedure. Okay. And the similar features and the differentiation of these stem cells are, the studies have stated. Okay. So the similarity of the features that are both the stem cells have the similarities: osteogenic differentiation, dendrinogenic differentiation, and low adipogenic potential. Whereas the cell proliferation rate is more in the stem cells from the apical papilla and comparatively less than that of dental pulp stem cells. Whereas the different feature is population doublings. In that also, stem cells from the apical papilla has more population doublings than the stem cell dental pulp stem cells. And the tissue regeneration capacity also more in the stem cells from the apical papilla. So this is what the regeneration helps the stem cells apical papilla plays a major role, and it has an potent in osteodentogenous differentiation and as mesenchymal cells from the bone marrow, but it has a weaker adipogenic potential. Okay. So now coming to the growth factors. So many growth factors which is present, and on that transforming growth factor, bone morphogenic protein plays a vital role in the regenerative procedure. These growth factors have a role in regulation of endogenous cells or stem cells requirement, migration, proliferation, and the differentiation. Now coming to the third ingredient is scaffold. These scaffold are porous, degradable structures that can be implanted alone or in a combination with the stem cells and the growth factor to provide a three-dimensional framework. This will support the cell growth. So without any missing of any one ingredient, it will lead to failure of the treatment. So scaffold, the types of scaffold, two types of scaffold, that is natural as well as synthetic. Natural, it is available, that is PRP, PRF blood clots, and comparatively PRF has more amount of cytokines and more amount of growth factors. So because of this, the PRF has a more vitality compared to the PRP and blood clot. Coming to the synthetic scaffolds, it is artificial scaffold. It is commercially available also. That is made up of polymers, and it has an polyglycolic acid, polylactic acid, polylactic co-glycolic acid, polycaprolactam. The main disadvantage of this synthetic scaffold is when we place at the site, there is a chance of getting inflammation, and also there is a chance of getting pain to the patient. And coming to the very important ingredient is environment. So this is what a well-sealed restoration in vivo to prevent contamination of the pulp, disinfection of the root canal system using medicaments and irrigants like hypochlorite and chlorhexidine and antibiotic base. That means the environment should be free from aerobic as well as anaerobic bacteria. So the environment should be sterile, okay, so that the these other three ingredients can work well. Now, American Association of Endodontics has indicated the certain guidelines for the regenerative treatment procedure. So the first indication is the teeth should be a necrotic. Second one is the apex should be open, that is an immature open apex, and the pulp space should not needed for post and co. Now, clinically, at the first appointment, so you have to explain all the risks and potential benefits should be explained. That means you have to explain the risk outcome of the treatment. So if you place the PRF inside the root canal, it may develop some pain initially, it may develop some swelling, and if the treatment gets failed, we can go for another treatment option, apexification and root canal treatment. And the benefits is we are going to gain the vitality of the tooth, and we can increase the survival rate of the tooth. And then collecting the clinical information, any medical or systemic drug allergy, and then establishing a pulpal and periradicular diagnosis. So this was the very important. The pulpal diagnosis should be done by vitality checking, okay, and there should not be any periradicular pathology. That means the lesion site should be carefully examined by radiographically. The lesion size is big, then it is very difficult to give the success rate. And then local anesthesia with an adrenaline has to be administered. Then under the rubber dam isolation, access opening has to be made. Followed by gentle, slowly irrigate with an 1.5 percentage of 20 ml of sodium hypochlorite for 5 minutes. That is, he had put on certain guidelines to irrigate the canal by using a hypochlorite. You have to use a lower concentration. Even the studies have showed 2.5 percentage also effective. 1.5% is effect of 20 ml of hypochlorite. Then followed by dry the canal by using a pepper points, and then place an disinfectant material, that is triple antibiotic paste or calcium hydroxide in the canal 1 to 2 mm short of the apex. Then followed by temporary filling cavity has to be placed at the coronal site, and then recall the patient after 3 to 4 weeks. So at the second appointment, you have to see any swelling or any signs or symptoms, any pain developed, any swelling or any sinus tract present, everything have to be examined, and then LA should be administered without adrenaline. So here we are not giving adrenaline because we need enough volume of blood at the periapical region. If you give adrenaline, there is a more chance of getting clots. So more volume of blood supply is present, then the growth factors and viable of the growth factors and stem cells will be good. And then followed by rubber dam isolation, then the temporary restoration has to be removed, and by use of 17% of 20 ml of EDTA to remove the intracanal medicament. Then final irrigant should be used as a saline, and followed by drying the canal with a pepper point. Then if you want to do the revascularization procedure at this level, so you have to take and file, and you have to lacerate the periapical region, and you can induce the bleeding up to 3 mm below the CJ. Okay, so if you want to go for regenerative procedure, still more of the contradictions are there. Either we have to initiate the bleeding or we should not initiate the bleeding. But still, I am facing, what I have done is, yeah, really, I have tried the both. I have initiated the bleeding very little, and I have placed the scaffold. And also, I didn't initiate the bleeding. I placed the scaffold as it is. But I can able to see the good result without bleeding also, without initiating the bleeding also. So if you want to do revascularization procedure, you can initiate the bleeding. Okay. So if you want to do a regenerative, you can place the scaffold at the periapical region. Okay. So you have to nicely condense the PRF to the periapical region. Better it gets penetrated into the periapical region. Okay. So always you have to use an if microscope or loops are there, it is very easy to use, and I have used a loop. Okay, so I can able to see up to coronal to middle third. I can able to see the moving of PRF, but still after that, according to the working length, we have to push the PRF inside the periapical region. So over that, resorbable matrix pull-up plug has to be placed, and 3 mm of MTA should be 3 mm below the CJ. MTA should be placed, okay, because to avoid the coronal leakage. And resin modified glass ionomer cement has to be done as a final restoration. Then recall the patient after 6, 3, 6, and 12 to up to 18 months. Okay, how will you prepare this PRP or PRF? Okay, the PRP is little bit technique sensitive, and we need some time, and also the blood is drawn from the vein venipuncture, and it is collected in a glass tub which is coated with the anticoagulant. Then it is centrifuged at 2400 RPM for 10 minutes. PRP and PPP from the red blood cells is separated. And then again it is transferred into another tube. Then again centrifuged to 3600 RPM. And then at the end of this cycle, PRP is precipitated at the glass tube. And this is retrieved by cotton and placed on petri dish, and then finally mixed with 10% of calcium chloride to activate the platelets. But still, this is the technique sensitive, and if you compare this PRP with the PRF, yeah, of course, PRF, it is very easy to do, and the minimum time for centrifuge is 1200 RPM for 8 minutes is enough, and sometimes 2000 RPM for 10 minutes is enough. You will get enough amount of PRF, and that is very easy to do. As well as when you decrease the centrifuge time, you will get more number of stem cells, more number of growth factors present in the blood. That is PRF as well as PRP. More number of platelets present in the PRF or PRP. So if you compare this PRP with PRF, of course PRF has less centrifuge time, and also the more stem cells, more growth factors will be present. Okay. And also the studies also proved that comparing this regenerative protocol with the apexification, yeah, of course, they have shown that root increase in the root width, root length are good in result. Coming to the factors that affects the results of regenerative treatment, this is a very important factors. Okay, AE has put on certain guidelines to increase the success rate of this regenerative treatment protocol. So the first one is degree of infection of the canal. So in case of very big lesion, more than 1 centimeter, it is very difficult to expect the regenerative, expect the root length increase. Okay, so in case of mild to moderate lesion cases, we can go with a triple antibiotic paste. In case of moderate to severe lesions, we can change the triple antibiotic paste twice, and we can go for an regenerative procedure. And calcium hydroxide also used to disinfect the canal. And the apex diameter, it should be more than 1.1 millimeter, so that the volume of blood gets loaded, as well as the more volume of PRF gets transferred into the entered into the periapical region. And the main thing is patient age, it should be 8 to 16 years, and it is completely contraindicated in the deciduous teeth. And in this procedure, the very important thing is removal of complete removal of the bacteria. Here, the multiple aerobic as well as anaerobic bacteria will cause the infection of the root canals, and it is very difficult to remove with the one type of antibiotic. So, one day the triple antibiotic paste is used, that is ciprofloxacin, metronidazole, and minocycline, and calcium hydroxide also used. Now, coming to drawbacks of this triple antibiotic paste, some patients may develop pain initially, and sometimes sinus tract also. And the very important drawback is minocycline, presence of minocycline. This may cause discoloration. So to avoid that, nowadays the studies also showing that replacing the minocycline with cefaclor and amoxicillin, as well as the newer antibiotic range like cefuroximine or aristine. And the MTA is used as a coronal filling material because it has a good biocompatibility and also good sealing ability, and especially it sets in a moist environment, such as the bleeding is induced in the canal. So now the future of regenerative, what is the future in the regenerative treatment? So now the future is, first one is 3D bioprinting. Yeah, of course, myself and my friend Dr. Thiru, we are planning to start up a 3D bioprinting studies. Already he had done 2 animal studies in 3D bioprinting at Hyderabad, and we are planning to soon, we are under its discussion. So we are planning to start a 3D bioprinting study in future. And this 3D bioprinting procedure is nothing but it is a synthetic 3D scaffolds. It is generated by a bio ink that is composed of printable alginate hydrogel with soluble and insoluble fractions of dentin matrix. And this 3D bioprinting is placement of cells into soft scaffold and directed by a computer aided design. This is completely bioprinting. This is designed by computer. Okay, and this enhances the odontogenic differentiation of the mesenchymal stem cells, and it is encapsulated in these bioprinted hydrogels. Such bioprinting allows to study cell interactions and the effect of cell organization on cell growth and function. The only thing is, this is a little technical sensitivity, and we don't have enough feasibility to do. And now we are planning to start that study also in future. And the other methods are like injectable scaffold, a type of 3D. This is also a 3D scaffold. It is composed of hydrogel and it promotes the bone regeneration. Then the gene therapy is applied here by delivering mineralizing genes into vital pulp cells of necrotic or symptomatic tooth. And the last one is bioengineered tooth. This is completely to replace the missing or lost tooth. And it is developed in vitro by replicating the steps of development of a tooth germ. Now coming to the outcome of this endodontic procedure. So I categorize into 3 outcomes. That is patient-based outcome, clinician-based outcome, researcher-based outcome. So from patient-based outcome, yes, patient has to free from signs and symptoms. They should not develop any further signs and symptoms. They should not develop any pain or swelling or any sinus tract or any discoloration. And the survival of tooth, yeah, patient is more conscious about their survival rate of the tooth. They want the tooth to be surveyed long time. And from the clinician base, of course, we want to see the radiographic changes. That is, we can able to see that improvement in the root length, improvement in the dentin thickness. That is very, very important. And also there should not be any lesion at the periapical site. And very importantly, we have to see the vitality response. That is what from clinician side we have to see. Whereas from researcher side, yeah, of course, they have doing so many animal studies and histological studies, histological evidence, but still now none of the studies has proved that the regeneration tissue is not a proper regenerative tissue. It is like an pulp dentin-like complex. It is like an connective tissue like complex. It's a cementum like complex that only they are mentioning. So these are the outcomes and the limitations of this regenerative procedure is the first one is patient cooperation. Yes, of course, the patient has to follow up for the treatment, and patient has to cooperate for the blood withdrawn, and patient has to completely has to do the proper follow-up till the end of the treatment. And the discoloration, of course, because of presence of triple antibiotic paste, we can change the minocycline, replace the minocycline, and we can go for amoxicillin or some other drugs. And MTA, sometime in MTA also may cause discoloration. So to avoid all those discoloration, better we can apply a bonding agent at the coronal site to avoid the leakage from the penetration of leakage through the dentinal tubules to the crown structure. And the outcome, unpredictable outcome, yeah, of course, we can't give assurity to the patient. Definitely we can gain the vitality as well as we can able to gain the root length. So unpredictable outcome, we have to wait and watch the treatment procedure. And the lack of expertise, yeah, of course, we should follow the proper protocols, proper sterile environment. We should the proper awareness and proper knowledge in this regenerative procedure, and we have to perform in the patient. So these are the limitations. So by this, I would like to conclude this regenerative endodontic procedures provide a successful alternative for the treatment of necrotic teeth with open apex and by permitting continued root development. However, current clinical protocols of regenerative endodontic procedure foster repair rather than the regeneration, but still, moreover, the resemblance of the regenerative tissue to a healthy pulp dentin complex is still debatable. And thank you so much for listening.
Arun, can you stop sharing your screen?
Yes, ma'am. Yes, ma'am.
Thank you, Arun. Am I audible? Thank you, Arun. It was indeed a great pride and privilege to have you as
Raj, can you please keep the... we are not able to hear you.
Yeah. Yes, ma'am. Yes. Thank you, Arun. It's indeed indeed a great privilege and pride to have you as one of our speaker. Whether you do things differently or you do different things, at the end of the issue is how you are going to uh, market yourself and how you are going to exhibit yourself. Your case reports are wonderful. I feel the documentation and the efforts you have taken to present your cases here. It is indeed it has to be really engaging and it is motivating to all our postgraduate students. I always insist the students to document their cases, and not only that, your sense of confidence in presenting your presentation, your scientific presentation today. I'm able to see that how confident you are and how much of research you have done for getting into this the field of regenerative endodontics. The clinical literature indicates regenerative endodontic treatment using various methods and materials, which results in significant increase in the root length. And this itself, are you able to hear me now? I'm seeing,
A bit, your voice is breaking actually.
I think some issue with the network or something.
I think
Am
it's
I audible? The other day it was fine, ma'am. I was sitting in the same place. That's why.
okay. Okay, yeah. No, it's coming clearly, but little break is there. That's okay. You can please continue.
Okay, ma'am. All right. This is a special field. This is an emerging field in part of endodontics. The tissue engineering of pulp, which will be the future scope of our field of endodontics. Now, do we have any questions, Dr. Kritika?
Yes, sir. Yes, sir. So the first question is, what more can we do in regenerative endodontics in terms of scaffolds used?
Yeah, in terms of scaffold, already it's natural scaffolds when we are having, we can go better with the natural scaffolds. Okay, so other than this PRF, the PRF is it's showing good result. So the natural scaffold which had a PRP or PRF, better we'll go with an PRF. It will show a good result. Other than that, synthetic scaffolds only we have to go, but there is a still synthetic scaffold shows a more symptomatic problems to the patient. So this is what studies have showed.
Okay, sir. So what's your take on cell-based and cell-free regenerative therapies?
Sorry, hello.
What's your take on cell-based and cell-free regenerative therapies?
Okay. Yeah, of course, cell-based and cell-free. If you see, the cell-based regenerative is more effective. It will show a good result than the cell-free. Okay, the cell-based scaffold always we will prefer, so that the more amount of stem cells as well as growth factors can help in the formation of, can help in the successful regenerative treatment.
So will there be any cell components at all in revascularization?
Sorry?
Will there be any cell components at all in revascularization approach?
Cell components.
Yeah.
Cell component, yeah, already I have shown you the stem cells from the apical papilla as well as the dental pulp stem cells. These two cells plays a vital role. Other than this, the cells which is already present, but still the stem cells from the apical papilla and the dental pulp stem cells will show a good result.
Sir, is there any way we can avoid this discoloration that is happening following regenerative endodontic therapy, sir?
Yeah, this discoloration is only because of two reasons. One is either due to triple antibiotic paste or by MTA. So for that only, I told replace that minocycline present in the triple antibiotic paste with an amoxicillin or the cefuroximine, the recent antibiotics that can be used as an alternative, as well as if you want to avoid, even the MTA can gives you a discoloration. So to avoid that only, we have to apply a bonding agent over the coronal area.
Thank you, sir.
Thank you.
Over to you, sir.
Yes, ma'am. I think we have done with all the questions. Thank you. And let us honor Dr. Arun, certificate of appreciation. And please
Yes, sir.
accept that.
Yes, sir. Thank you, sir. Thank you so much, sir.
Thank you.
As-
Thank you for that wonderful insight into regenerative endodontics.
Thank you, ma'am.
You have made it sound very, very clinically. You have explained a lot of things, which we talk about regenerative endodontics in terms of research. You have done more clinical work, which shows in your presentation. Thank you very much.
Thank you, ma'am. Thank you so much, ma'am.